Thank you very much, Felicity, for inviting me. I'm feeling a little overawed because there's some of the great and the good in the whole sort of panoply of NHS campaign world here tonight. So I really hope that you'll bear with me and hope that I'm not pitching this at too low a level. But I will say that the way that I've chosen to approach this tonight is because I have been attending quite a number of meetings from local campaign groups across the country. And I am very conscious of a general approach to the white paper and to integrated care in particular, which is based on people believing that the white paper needs to be halted, there needs to be more time to think because this isn't going to work properly, this isn't going to integrate health and social care properly, that not enough thought's being given to it, and various things of that kind. So what people seem to be focused on is detail and process, rather than actual policy and objectives in what's going on. So I'm going to start with an old joke. A man takes his suit to the 3-hour dry cleaners. That'll be ready next Thursday, sir, says the shop assistant. Next Thursday, says the man, but it says 3-hour dry cleaners on the shop front. Sorry, sir, replies the shop assistant. That's just the name of the shop. So why am I telling this joke when I'm talking about integrated care? Because integrated care is a dishonest label, misleading about its content. It's not about collaborative working between local authorities and the NHS in order to improve patient care. Integrated care is a financial accounting system imported from the USA, designed to cut costs and enable profit sharing. And I hope tonight I can explain why that's the case and why it matters. Quite explicitly, through policy and legislation over 30 years, the NHS has been moved away from a public service to a mixed economy of provision. It's slowly bringing the NHS into line with the rest of the world. It's not exclusively a Tory plan. It has support from across the political spectrum. Health is big business globally, and healthcare like ours was publicly provided, owned and financed, restricts the business opportunities of foreign companies and NHS bodies alike. Polls show that a very high percentage of the population wants the NHS to be public, but politicians and think tanks aligned with global health interests have consistently moved it away from public service. This is reshaping healthcare to provide profit opportunities at every level. Because politicians know how much resistance there is to this reshaping, it has been done under the cover of consultations with predetermined outcomes, outright lies about what's being done, especially about hospital closures, and protestations of how much various governments love the NHS and would never, ever privatise it. When I say there are profit opportunities at every level, I start with the top level of policy and management because that's where it matters most. Most campaigns are centred on local cuts, closures, and reductions of service. That's where it grabs our attention. That's where it hurts. But if you don't look upstream at where the bodies are being pushed into the water, you'll be fishing them out downstream until everything you care about is gone. At this top level are some of the world's biggest global health insurance companies. Global management consultants advise on both sides, the government and the corporations. The big four accountancy firms, PwC, Deloitte, EY, and KPMG are in there too. Not just getting contracts to provide services, but being paid to tell the NHS how to cut its services. We are paying people to take our healthcare away. This is not a question of lobbyists or influence. It's about who is running and making decisions about the NHS. And for any councillors who might be here tonight, it's for local authorities too. Outstanding moments from the last 30-year process include the supposedly independent Nuffield Trust, bringing US Medicare provider Kaiser Permanente and his lobbyist, Professor Alan Enthoven, to advise Thatcher's cabinet on the 1990 Act, which broke the NHS into an internal market. New Labour's Alan Milburn, extolling both Kaiser Permanente and United Healthcare, brought Kaiser in to run NHS beacon projects with trusts, and United Health to advise primary care trusts on how to run their systems. This is a process, not a one-off in the current white paper, and understanding that should strengthen the focus of campaigning. Both these interventions of United Healthcare and Kaiser into the NHS were based on a particular concern of the US healthcare industry, and they are important in terms of integrated care. It's how to reduce the cost of expensive patients, mainly those with long-term sickness and disability and the elderly. If I can emphasize here, this is about reducing the cost of expensive patients, not about improving healthcare. As the ideas of changing the way the NHS operates were being brought in, so the US insurance industry was concerned about its Medicare patients, who were spending about twice as long in hospital beds as private patients. And those many of you here who understand inequalities of health will know that the poorer population in America are the ones getting things like Medicare and Medicaid, and therefore the ones most likely to suffer the longest term consequences of illness. They developed the principle of day surgery with no overnight or aftercare provided for their Medicare patients. As one executive is recorded on camera as saying, "There's no profit in having the Medicare patients using beds. We free them up for private patients." They started to move to managed care, where the services a patient can use are limited by agreement between the insurer and a limited group of providers. Payment is made on a capitation basis, a fixed amount per registered patient. There's a thing called a risk pool, which is a critical component of healthcare payment systems. It's fundamental to understanding integrated care. In a public service NHS, the risk pool is the whole country, and the payment is assumed by the government on behalf of the whole country. Estimations of cost are made at the beginning of the year, reassessed usually halfway through the year, then any shortfalls picked up by the Treasury at the year end. The government can decide to be tight or generous with funding allocations. At the end of the day, the risk and the cost remains at national level. Not so with managed care, where risk is passed on to the provider group, and not so with integrated care either. Risk pools are concerned with who shares the risk. For example, the GP shares the financial risk with hospital care in some of the new NHS new models of care. In some areas of the country, we already have GPs being paid incentives not to refer patients to hospital. In a 2018 report commissioned by NHS Midlands and Lancashire Commissioning Support Unit from NHS England's Strategy Unit, it states that risk and reward sharing is a key feature of the policy agenda for accountable care organisations in the US and integrated care systems in England. It offers commissioners the opportunity to co-opt and incentivise providers to moderate growth in healthcare demand by sharing in the savings or cost overruns. Risk and reward sharing can be seen as a step in the journey towards the full transfer of financial risk to providers. Those providers are the 42 integrated care systems. In 2012, management consultants McKinsey co-wrote the Health and Social Care Act with Andrew Lansley's health team. NHS England itself was tailored by McKinsey according to a model it set out in a presentation to the Department of Health in February 2011. An email from an unnamed McKinsey executive from May 2010, just as the coalition government was being formed, states, "We have been gathering our thinking on the implications of the new government programme for the NHS and have started to share this with clients. Would you like to meet us to discuss it?" The email was sent to David Bennett, then the chief executive of Monitor, whose role was to police the relationship between the private and public sectors. Bennett himself had spent 20 years at McKinsey, which you may know prides itself on its former employees never losing touch and always working together no matter what other roles they go on to occupy in their working lives. Bennett left in 2016 when NHS Improvement took over Monitor's functions and went to work for the Serco-owned pathology company Viapath. Just after the 2012 Act was enacted, it became officially labelled a mistake on all sides of the political spectrum. In our, that is Public Matters, analysis of the developmental path of the NHS from a public organisation to a set of fully public-private local health economies, the 42 Integrated Care Systems, the Act was not a mistake. It was essential both to create a bigger rupture than had previously been achieved and to bring the private sector in at a scale and pace previously unachievable. These private providers are destined to become part of integrated care systems. Integrated care has been prefigured over the previous years, but started in earnest with the appointment of Simon Stevens to the post of CEO of NHS England. Stevens was part of Milburn's New Labour Health team, but spent the intervening 10 years in top positions in United Healthcare. Others in the running were Kaiser Permanente's CEO Bernard Tyson and Mark Britnell, the director at KPMG. These people were never being considered because of their long history of commitment to public service. I could spend all day listing the various movements between political office, advisory positions, and the private sector, and which companies are directly advising on service changes which will benefit them directly. But I hope that I've given enough of a flavour to make two things crystal clear. First, that the confederation of interest between politicians, global healthcare, and think tanks over the last 30 years, as well as right now, do not indicate that the NHS is being shaped and run in patients' interests. Although I will call out here for the extraordinary, slightly unbelievable dedication of staff who try to make it so unbelievably against the odds. And secondly, that funding hasn't simply been cut. The message that the NHS is being underfunded is one that we often hear. But the NHS has faced that before and weathered it. This is about directly funding in different directions to achieve a different purpose, one which favours profit. For 30 years, our successive governments have used language that sounds like care to cover for the dismantling of the NHS. Integrated care is yet another of them. It's not about collaboration between health and social care to improve patients' lives. That's why it seems so consistently to fail to meet its supposed objectives, because they're not the objectives at all. But no party has ever offered the electorate an explanation or allowed them a choice at the ballot box as to whether they want this. What can we do? Keep fighting locally, but build a more concerted national campaign to hit the top levels of concern, not just the local closures. Because I think this particular change may be much harder to row back from in the future, should we ever have a government, again, that truly believes in and will legislate for public service.